is a pneumothorax. And you have to know how to look for that. But here's a definite, this is not a skin line. This is a collapsed, skin line summit is usually in a small area. This is a fully collapsed lung, okay? Increased density here, and very, very dark in here as opposed to this side. So this is a pneumothorax, a collapsed lung. Make sure you know that. Also, there's an effusion here. This is fluid filled in here. This is all an effusion. It's what it's doing is obscuring the right cardiac order, right hemidiaphragm, and the whole right costophrenic angle. You can almost see an elliptical sign here, like there's fluid in here. And this is a CT patient laying on the back, and the fluid is layering. Do you understand that? Do you guys see that? We don't know what the etiology, radiology. You can get an idea what things are, but histologically it makes the definitive diagnosis. I don't know what the reason for this is. I don't know if this is a malignant effusion. I don't know what it is, but it's definitely an effusion. Look, just look at this again. This is 2 studies, a chest x-ray. You can see that it obscures the right hemidiaphragm. You see haziness here. You can almost see an elliptical sign in here, like when you fill up a test tube, you see a little meniscus in there. And on the right side, this side's completely clear. The corresponding CT where the patient's laying on the back, the fluid drops and it layers out. This is important to know on these 2 studies. You got that, guys? You see it? And you understand the pneumothorax, right?
Can you repeat what you said about the CT?
Patient's lying on the back. Here's the vertebrae, right? So if the patient's lying on the back and they got fluid in it, what's going to happen? The air's going to go to the top and the fluid's going to lay around. If it's free fluid, this is free fluid. I don't know what kind of free fluid it is, but it's free fluid. So the fluid drops to the dependent portion, and then what happens is that like you have the water balloon filled up, the water reaches a line and the air goes to the top. This patient's lying on the back. This is a right-sided pleural effusion, both on CT and X-ray. Got it? Yep. Okay. There's a massive effusion here where you can barely see anything. This whole thing is obscured. Everything is there's a small type of, you can actually see the fluid here. This is a massive pleural effusion. Any questions about that? You guys recognize this stuff?
Yeah, you could notice that one, definitely.
All right, well, I just want to make sure. Not a guessing game, huh?
Would we have to write in our answers?
It's all going to be multiple choice. It can be selections.
Okay.
You know, and sometimes it's not just 1 for 1. It's either this, one thing. One picture can be, the same thing could be atelectasis twice, or it could be effusion twice, or a pneumothorax. It's going to be selection. It's recognition. It's not a trick. It's not, oh my God, he's trying to share. What is it? It's just try to think. Yes.
In the previous picture, how did you describe the right side? Were you only concerned with the left side being?
Well, I'm just trying to show you pathology. What do I say about this?
Yeah.
It's a bad picture. I can't even see anything. The bottom line is that I want to compare one side to the other. I can't see the right hemidiaphragm. I don't know what's going on back here.
So you're just concerned with the massive division on the other side?
Right. If you see a picture like this, and somebody says, what do you think this is? And you got a choice, you pick out your choice. All right? The disadvantage about taking these exams sitting here is you don't have the patient in front of you. So that's the whole thing. All right? Guys? Okay, so I just want you to recognize problems. Because you're going to get on the phone at 2, 3 o'clock in the morning and say, well, they said the resident or the attending, listen, I got a patient here, we did a chest x-ray, the shortness of breath, patient has a fever, there's a white count. Oh, what do you see? I don't know. There's something there. I don't know. But you got to be able to describe it, thinking about the history, the physical, and what's going on. Well, maybe the guy's got an effusion. Maybe it's a massive infiltrate. Maybe it's, if it sounds like a horse coming toward you, it's probably a horse. You think you hear hoof marks, hoof sounds coming. It's not going to be an elephant. It's probably going to be a horse. So think about the most common stuff that you're going to see. You know what I mean? Here, important, very important, right over here. We have 2 views of the chest. This is a decubitus, because the patient is lying on the side. Look, see these arrows pointing up? That means that the patient is laying down on the side like this. because they saw an effusion over here. They said, it sounds like an effusion, it looks like an effusion. Let's do it with the cubitus to see if it layers, okay? So this is a PA or an AP shot. We see this big area obscuring everything, the right-handed diaphragm, everything. So they said, let's see what we can get to tap this patient so that the patient can breathe properly. So we lay the patient down, do the cubitus. You know what a cubitus film is, right? So you lay the patient down. So what's free fluid going to do? It's going to layer out, right? Look, this is telling us that it's up. These arrows are showing us that there's something going on here, and it follows like meniscus. It's like a meniscus on when you fill up a test tube.
In the exam, are the arrows going to be there?
I don't know. I don't know. This is not going to be there. You figure it out. You know this is not a PID, right?
Yes.
You listen, can't give it all away. All right, look. One of the 6 different things that alter a normal chest X-ray is masses, besides being atelectasis, besides being airway disease, besides being emphysema, besides being interstitial. This is a mass here with air fluid level. This is a double thing that's going on here. Not only do we see a mass in the right upper lobe, which may be tuberculous, it may be infectious, it may be fungal, I don't know what it is. There's something that looks irregular on 2 views with an air fluid level. Do you see why it's an air fluid level? Because it's like a line, because we have that sign, that meniscus sign. Everybody see that? Do you understand that? Yes? Okay. And this is only showing you that in certain posterior mediastinal tumors, on a PA view, you can see that the contours are irregular. I know we spoke about contours and stuff like that. And until you do a lateral view, you can see this probably a neurogenic tumor in the spinal cord. See that? All right. And this happens to be multiple circumscribed lesions in the chest, most likely metastatic, that vary in size and shape. All right? Good. Bullae formation and emphysematous changes. Emphysema will alter a normal carrying X-ray. Increased markings. Bullae formation. This is not a pneumothorax. This is large bullae formation.
Would you go back to that for a second?
Yeah.
Please?
Yes. Wow.
Okay.
Wait, do the lungs look smaller, or is it just...
You know what? It's not a question of lungs being small. There's no parenchymal pendants due to bullae formation. The actual vial may be larger, but there's no lung capacity because this is all large bullae formation as opposed to this side, the left side, which has some bullae, normal parenchymal patterns. But this is all full of bullae. This alters normal appearing chest X-ray. Emphysematous changes, hyperlucency, widening of the AP diameter, barrel chested, right? Increased markings, small heart. There's about 5 different things that when you see a COPD or an emphysematous chest, you'll just know it. After you see a lot of them, you'll know that it's an emphysematous chest by history and everything. Patients breathing, having trouble breathing, can't walk 2 steps. This lungs are so black, it's almost as black as outside the film. You'll see a lot of this, okay? Interstitial markings, reticular nodule in different diseases like, different interstitial diseases. Honeycomb, connective tissue disorders. More interstitial nodules. Okay, look at this. You know that there's a collapsed lung here, right? You definitely know there's a collapsed lung here. Look at the right side here. Now this is a CT chest of CT of the chest. The patient's lying on the back. You can see that there's a thoracic spine, and you can see that this patient has some disease, maybe emphysematous changes, increased markings. It's not a clear parenchymal pattern. But one thing you know is that the lungs are fully expanded here. The lungs are not fully expanded here. This is a pneumothorax. Is that clear to you? Attention pneumothorax. Do you see that? Okay? If you recognize that, you're going to be seeing lots of this. And you're going to have to be able, on the spot, to know what's going on. And this might have been done from an outside, maybe there was a stab wound or a bullet wound. We don't see the bullet here. But you definitely see a rib fracture here. You see that, guys?
Yes.
So here's a rib fracture. So maybe this rib fracture cut right into it and created that pneumothorax. Yes? Yes.
Why do you have like extra parenchymal like markings?
Here?
Yeah.
Well, for a couple of reasons. Maybe this patient has a disease. Maybe there's infiltrate. Maybe this patient's very sick. Remember, they just don't come in with one thing. They come in with 16 different things. You know, they got hypertension, diabetes, this, that, and the other thing. They got pneumonia. Maybe there was this patient's emphysema. Maybe there's a blood that was blown that created this pneumothorax. I don't know. But not everything is just one thing when you're going to be in the ER or up in ICU, CCU. It's going to be a multitude of problems. So there might be more things going on. The main thing is that maybe this patient fell out of bed and hit against it was in the shower and hit against on the shower, walking into the shower, and ended up with a rib fracture created. And because of that rib is like a knife when it cracks, it created a pneumothorax. Do you see the difference? Do you see the difference in it's completely black just like out here? You know that's a pneumothorax. And there's a shift of the mediastinal structures to the opposite side. Any questions on that? Okay, very clear, right? Crystal clear. Just to show you real quick how some masses in here, you can't sometimes tell if they're masses or what's going on, or an infiltrate, but when you do a CT scan, you can see that there's a pleural-based mass here, and there's bony destruction right in the rib cage right over here. Okay, do you remember I gave this sheet out to you just to show you? I just want you to know and be familiar with all the different things that can change the normal appearance of a chest X-ray. These are the things that can cause problems. Airway disease, this is a normal appearing lung. And these are all the types of atelectasis you can have. And this is the passive one is the pneumothorax because it's collapsed but it's still functioning. Compressive is when there are other diseases pushing against the lung, like a pneumonia to create like a partial. And this is scar tissue. This is atelectasis. There are 5 different types, and over here is all the different things that can cause a change in pattern of a normal appearing chest X-ray. Okay, got that so far? Good. We're going to move on. Fun, right? Yeah, I can see that.
So much.